it's time to begin. And as usual, the light is in my eye, but there you go. Welcome everyone, and Happy New Year. This is the second event in this year's Brain and Mind series. The overarching theme for this year is mental and physical health. Last term, we discussed anxiety and the brain, and next term, we'll be discussing movement, sport, and the brain. And this is on the back of your program. I know I said that last term and it wasn't there, but this time it really is there, so you can look on the back of your program and get the date for our next event. Tonight, our topic is eating disorders and the brain. These events are open to all members of the university, members of the general public, and notably to students from various secondary schools in and around Oxford. I want to give a special welcome to any A-level students who may be here this evening. Can you just kind of raise your hand if there are any? Oh, good, excellent. I've maybe seen some of you before. That would be interesting. I'll talk to you at the interval. I also want to mention that these events will be available, they are all available on YouTube, and we usually post them a few weeks after the event. Now, there are a whole lot of events you can catch up on these YouTubes, as Brain and Mind has now been running for 11 years, and we've covered over 30 topics. We do 3 a year in that time. To give you a flavor of what you can find, we've covered topics such as art in the brain, music, reading, hearing, and so many more. I urge you to look at these YouTubes and also to look out for future events. I should explain that we run these events in conjunction with the medical school in Hamburg. Dr. Micah Glitch, who teaches at the medical school, was for many years my colleague here at St. Hilda's, and together we came up with the idea for the series. Dr. Glitch and the Hamburg audience are usually on the big screen. We can see them in their room. But there's a transit strike in Hamburg, and I'm told it's minus 7 degrees. The temperature is minus 7 degrees, and that means that they can't gather in the room at the medical school. But they're going to be listening online. So I extend a welcome to our scattered audience in Hamburg, and I'm hoping that you keep warm. There'll be 2 opportunities for questions from our audience tonight, one after the first 2 talks, after neuroscience and psychology, and another after the third, which is philosophy. Questions from Hamburg will be conveyed to Georgina Summers. Georgina, raise your hand. There you go. For her to read out. And I just want people to know who Georgina is because she's our current board member. She's a graduate student who is on the board. And Dr. Glitch, Georgina, and myself are board members, and another board member is Dr. Anne Dowker from here at St. Hilda's, at the end of the table. This event is funded by St. Hilda's College, and the funding covers, as among other things, the coffee and tea and cakes that you will have and enjoy at the interval. It also covers travel and accommodation for our speakers. Now, unfortunately, our funding is, to a certain extent limited, and it doesn't really allow us to bring speakers in from far and wide. Travel expense, especially rail fare, being what it is these days. So in order to ensure that we can get the best speakers and the best researchers in the area, we want to encourage people to give us perhaps little donations. Even 5, 10, or 20 pounds is actually plenty for us because it all adds up. And then we're hoping we can sometimes bring in speakers from a little farther afield. Now, I can tell you that we've already got some small donations, and it's making an enormous difference to us. So as I said, a little bit goes a long way, and there's a barcode on the back of your program if you would like to contribute. Now, as many of you who are regulars will know, these events are designed to bring together eminent researchers from 3 disciplines: neuroscience, psychology, and philosophy. And they speak about a topic that's of common interest. We don't ask that the speakers confer beforehand or try to make their talks coincide. We simply choose speakers who are experts on the topic in hand and then ask them to talk about how it is that their discipline approaches the understanding of that topic. What I find so utterly fascinating, especially I hope for our younger scholars, is just how different the approaches from each of these disciplines can be. And yet, each discipline is aiming to research the same topic. It's our experience over these 11 years that the time we spend together in discussion is fruitful for all involved. Our topic this evening is both a fascinating and a particularly delicate one. I want to begin by reminding the audience that tonight's event is following the format of all previous events. While we only offer the perspectives of neuroscience, psychology, and philosophy tonight, we appreciate that we could offer even more perspectives. In particular, we're conscious of the fact that in many fora where the topic of eating disorders is under discussion, it's usual, and maybe even considered by some good practice, that the panel include the perspective of someone with what has come to be called lived experience. That is, someone who has experience with the so-called disorder or condition. Now, while we appreciate that this perspective is an extremely valuable one, we also remind our audience that the event is neither solely from the perspective of psychology, nor is it a clinical workshop. And I should emphasize, we're not giving advice on the topic. All we're aiming to do tonight is showcase how 3 academic disciplines go about trying to understand the phenomenon. Finally, I want to say, if anyone in the audience feels uncomfortable at any point in the proceeding, please feel free to leave, and perhaps go and have a cup of tea outside. But if you are able to formulate a question, we encourage you to ask it. And we ask anyone who does ask a question to be sensitive in the way that you formulate your questions, bearing in mind that there may be people who are in some way affected by the disorders that we'll be discussing this evening. And I ask that the audience in Hamburg also take note of this, please. Now, with all this in mind, I want to turn to our first speaker, Professor Sylvane Desrivieres. Professor Desrivieres is Professor of Biological Psychiatry at the Institute of Psychiatry, Psychology and Neuroscience at King's College in London. And the title of her talk tonight is Anorexia and the Developing Brain, From Shared Risk to Recovery.
Thank you. Thank you very much. I need to see my PowerPoint. Thank you. Thank you very much. It's a real pleasure for me to be here today and to be part of what I think is a great idea, bringing at least 3 disciplines to talk about our work, in this case, eating disorders. So today I'm going to talk about eating disorders and the brain, but I will take a developmental perspective and not focusing on what's happening in the brain when the illness is already established. I will be asking 3 questions, 3 main questions. First is, what are risk factors or shared risk factors for eating disorders? And then, how do eating disorders, or eating behaviors rather, develop, especially during adolescence? And then finally, how can we use this knowledge to understand and learn more about recovery and the relationship between brain and behavior in the recovery process? This is because eating disorders usually do not come out of the blue. Yes, they typically occur during adolescence. And adolescence is a period that is highly complex in terms of biological changes, psychological and social transformation that the individual are confronted with. And very importantly, eating disorders are found to be highly comorbid with disorders, especially with ADHD and anxiety and depression, so internalizing and externalizing component of mental health disorders. And And so this really suggests that there is a developmental component in eating disorders, and that we should pursue a developmental approach if we want to identify ways to intervene earlier and to improve our treatments. And we address these questions using two complementary cohort data sets. On the one hand, we have the Imagine cohort. That is a data set that was collected from adolescents, first recruited to the study when they were age 14, and then follow up through adolescence until they reach age 23. And this data set is very important for us to understand early risk factors. This is complemented with clinical samples where we recruited individuals, participants with an eating disorder, or who had recovered from an eating disorder. And this is important if we want to understand diagnostic processes and the recovery processes. And then combining those two cohorts really help us to link early neurobiology with later clinical expression and recovery process. So a series of longitudinal data longitudinal studies that we have used using this data set have showed us that eating disorder symptoms such as dieting, purging, or binge eating are preceded by risk factors. And there is a series of shared risk factors that increase the risk of developing future disordered eating symptoms that include genetic vulnerability, genetic liability, for example, genetic risk for higher BMI, ADHD, or personality traits. And then internalizing or externalizing behaviors also predict future eating disorder symptoms. And what is important is that really this shared or general vulnerability is not specific to eating disorders, not specific to anorexia nervosa or bulimia nervosa, but can be shared with other mental health disorders, especially ADHD, as I mentioned before, conduct disorders, and depression, anxiety. When we look at the brain, we can also already identify brain differences that occur years before eating disorder symptoms appear. We can see, for example, that dysfunctions within the brain reward circuitry predicts future binge eating, while differences in brain area, prefrontal brain areas that are involved in control or affect precede the development of eating disorder symptoms of purging type. And those brain differences are not only specific to eating disorders, but also are shared within comorbidities, such as conduct disorders, ADHD, and predict also future depressive symptoms. So very importantly, we find that brain differences already are present years before eating disorder symptoms develop. So one thing it is important to realize that premorbid risk is different from brain differences when the disease is already established. So when we look at the brain in participants with already established eating disorders, so anorexia nervosa or bulimia nervosa, we do see differences, changes in the brain. You can see here comparing eating disorder brains for participants with eating disorders to healthy controls. There are areas in the brain that you see colored here that have a lower volume when we look at gray matter volume in participants with eating disorders compared to controls. And this is specifically a characteristic of the participants with anorexia nervosa. So there are profound brain differences, but those brain differences really reflect the illness itself, index states such as chronic stress or maintenance of the disease, and not a premorbid rates. So we have to be very careful when we interpret and analyze such results. And this is the reason why, instead of working with groups of participants with eating disorders, we have analyzed eating behavior patterns in the general population. So what we took here is we took young adults, age 23, and we clustered those individuals into 3 distinct eating behavior groups. One group were composed of healthy eaters. There were a group composed of restrictive eaters or emotional and uncontrolled eaters, and we analyzed their behavior. And this really is important for us to, it can be more informative to us than using really clinical diagnosis to understand the disease. So when we looked at, so age 14, participants with restrictive eatings or emotional and uncontrolled eatings already had differences compared to healthy eaters. First of all, they had advanced pubertal development, so they went into puberty earlier than controls. They also had a tendency to have a higher BMI, body mass index, compared to controls. Now, when we look across adolescence, so into young adulthood, from age 14 to age 23, we identify distinct trajectories. First, groups with emotional or uncontrolled eating, they were characterized with more internalizing behaviors. Initially, already at age 14, then increasing internalizing behaviors. They also had higher levels of externalizing behaviors, something as conduct problems or things like that. And also looking at their trajectory of eating disorders symptoms across adolescence, they experience increased rates or levels of dieting, binge eating, and purging. On the other hand, restrictive eaters, they had higher internalizing problems. They also had higher dieting during adolescence, but they did not have higher levels of externalizing problems. Now, looking at brain maturation, so how the brain developed from age 14 to age 23 in those groups, we see that normally the brain volume or thickness decreases during adolescence. There is a decrease in brain volume from age 14 to 23 in healthy eaters. But those reduction of brain volume are less important in participants with emotional eating or restrictive eatings. What is important is that those differences occur in different brain areas. In the cerebellum here for restrictive eaters, and for emotional or uncontrolled eaters in the cerebellum, but also in brain areas that involve the prefrontal cortex. So they seem to have a distinct maturation patterns, brain maturation patterns, which are suggestive of altered neurodevelopmental timing rather than just global changes in brain structure. So this data suggested to us the existence of 2 developmental pathways in terms of eating behavior. So these results suggest to us that there are 2 developmental pathways for eating behaviors across adolescence. For restrictive eating, we have originally genetic liability, for example, higher BMI associated with higher BMI at early adolescence that influences brain maturation in the cerebellum. And this might promote restrictive eating. On the other hand, emotional and uncontrolled eating, this group is characterized by elevated impulse control problems, which are tied to differences in maturation of the prefrontal cortex, and then leading to a future onset of emotional or uncontrolled eating. So And this matters clinically. It matters because it helps us understand how eating behaviors develop and how individuals with the same diagnosis, eating disorders, can be so clinically different. It also helps us to improve intervention and treatment by targeting rather early shared risk for eating disorders and targeting mechanisms instead of targeting labels. You know. And I think also it forces us to rethink about what we understand about recovery. When we look at recovery, clinically recovery is usually defined with weight restoration or symptoms reduction. But however, we know that the rate of relapse is very high in people with eating disorders. And also we know too little about the relationship between brain and behavior in recovery. So this is the type of analysis that we are currently doing when we analyze our participants who have recovered from anorexia nervosa or bulimia nervosa, comparing them to participants who are currently have an eating disorders and with controls. I will show you not the results because those analyses are not published, so I cannot share the details, but I can tell you the message of what we've found. So what we found is that in recovered anorexia nervosa or bulimia nervosa participants, they do not have symptoms of eating disorders anymore. Yeah? So they would be recovered from their eating disorders symptoms. However, many other symptoms related to mental health are persistent in recovered participants. So this is illustrated in this plot. What you see here in the green lines are healthy controls. They score high for symptoms of general good health, yeah? And low for the other symptoms that are mental health related symptoms. On the contrary, participants with anorexia nervosa consistently show high level of mental health symptoms, especially emotional and behavioral dysregulation. In recovered participants in blue line, those symptoms of behavioral and emotional dysregulation remain high and are not down to control levels. So they remain really high in the recovered participants. And some symptoms even increase further, yeah, more than in the acute group of patients. And we see that for anorexia nervosa, we see that for bulimia nervosa. When we look at the brain changes during recovery in anorexia nervosa, what you can see here is that we know we reproduce our expected results. So this is the brain cortical and subcortical brain areas that are different in participants with anorexia nervosa compared to control. In blue here, these are brain regions that really are smaller, have a smaller volume or thickness in participants with anorexia nervosa. So there are really widespread brain differences. When we look at the recovered participants compared to healthy controls, many of those brain differences have disappeared. Yeah. So this is what we call normalization of the brain. But on the other side, other brain areas do not go back to normal. The difference becomes even higher, which suggests that not only we have normalization and partial normalization, but we have also compensatory mechanisms and not a general return to baseline during the recovery process. What we have also done is that we try to link and couple those changes in the brain during recovery to changes in behaviors, in symptoms, to know which brain areas, changes in which brain areas relate to which symptoms changes. And we do that because it's important for us to try to identify brain target for treatment and relapse prevention. And this analysis led us to a way toward a redefinition of recovery based on mechanisms more than just binary diagnosis. So we found that recovery really is a process that involves adapting, coupling, and recoupling of brain and behavior. And that recovery might look slightly different in participants with anorexia nervosa and bulimia nervosa. And this is important now when we think about disease prognosis and how we can use that to prevent relapse. So to summarize, I have shown very quickly that eating disorders have shared developmental vulnerability. So this is a developmental risk that includes genetic liability, pubertal development, and emotional and behavioral perturbations, and this is linked to brain development in specific brain areas. And those shared developmental vulnerability may give rise to diverging patterns of eating behaviors during adolescence, and may or may not lead to expression of the disease with a clinical diagnosis of anorexia nervosa or bulimia nervosa. And finally, that recovery is a process instead of a binary state, diseased or not or recovered, and it involves behavior regulation and brain behaviors, recoupling, and that will help us to identify new targets for intervention. Yeah. I thank really above all the study participants, my colleagues. I thank you for your attention, and I'm really looking forward to the discussion.
So, thank you very much. As usual, we get started at the bottom layer, now we'll go up a level, and we'll hear from our psychologist tonight. Our second speaker is Dr. Rebecca Murphy, and Dr. Murphy is a clinical research director at CREDO, that is the Center for Research on Eating Disorders here in Oxford. And she's also an honorary clinical psychologist at Oxford Health NHS Foundation Trust, and the title of her talk this evening is Understanding and Treating Eating Disorders, a Psychological Perspective.
Okay, thank you so much for inviting me to this really interesting cross-disciplinary and international set of talks today. I really enjoyed hearing Sylvane's approach. Thank you so much. So, I'm going to be talking to you a bit about how to understand and think about treatments because I'm a clinical psychologist. I also run our research group. We specialise in developing and evaluating psychological treatments for eating disorders. And yeah, I'm lucky to be part of a team, so I want to thank all my colleagues who've previously worked with me and who work with me now. Starting off with just a little bit of an understanding of what eating disorders are. And as you can see, you're probably going to hear from different people who have different ways of understanding what eating disorders are. So we have some definitions of eating disorders as psychological or psychiatric constructs, and oftentimes these definitions rely on thinking about the ways in which people's eating is disturbed in some way or is sort of affected. And quite often with eating disorders, what you see major impacts on people's lives. This might include behaviours designed to try and control weight or control eating or control body shape, and the degree to which it becomes a disorder depends on how much it gets in the way or interferes with people's daily life. So, There are different types of eating disorders that you've heard a little bit about already from Sylvane. So traditionally, eating disorders are divided into different diagnostic categories based on what sorts of features an individual presents with. And so you may have heard of some of these: anorexia nervosa, bulimia nervosa, binge eating disorder, and there are other types of eating disorders as well. However, our group takes a little bit of a different approach, and as clinicians working with people with eating disorders, what we notice more is what people with eating disorders have in common, rather than the differences between different types of diagnoses. So our approach is less concerned with a particular diagnosis, and it's more concerned with the particular individual's difficulties that they're having around eating shape and weight. So, what are some of the common features of eating disorders? I want to start off with one that people don't often think about when they think about eating disorders, but it might be one of the most central components, and that is about people's systems of self-evaluation. What I mean by this is, how do we all judge ourselves as people? How do we work out if we feel good about ourselves as a person, or if we feel bad about ourselves as a person? And quite often, we'll all have different domains or areas that inform our sense of self-worth. That might be work, it could be relationships. There are lots of different areas that each of us perhaps strive to do well in. And if we feel we're doing well in those areas, we might feel good about ourselves as a person. If we feel we're not doing well in those areas, we might feel bad about ourselves as a person. So what we find is a lot of people with eating disorders tend to judge their self-worth largely or even exclusively in terms of eating shape and weight. And for some people it's about whether or not they can control those areas. For some people it's not about control, but it's more about how they feel they're doing in those areas. And for some people it's a combination of eating, weight and shape. For some people it's more about eating. For some people it might be more about weight. So it can take different forms. But the key is really trying to understand the way in which these areas dominate people's sense of self-worth. So an example quote here is, "I feel so disgusted with myself as a person when I fail to stick to my diet or my weight goes up. I lose all hope for the future." So you can see that in there, it's really key the way in which this person's sense of self-worth is dependent on whether or not they feel they're doing well in the area of, in this one, eating and weight. And this is very different from what some of us might experience or see in our daily lives around perhaps feeling as if there's a thin ideal that society is telling us we should aspire to, and maybe we don't feel we happen to meet that or not. And sometimes people might feel dissatisfied about that, but that's quite different from a system of self-evaluation which is heavily dependent on these areas. So, what are common features of eating disorders? I've spoken about one of them, which is the system of self-evaluation. What you'll often see are concerns or worries that people have about eating, weight or shape. People might check their body, looking in the mirror, weighing themselves, or they might avoid finding out about their body. They might be wearing baggy clothes, getting dressed in the dark. These are types of behaviours that people engage in because they're so worried about their body and about their eating, weight and shape. Can you tell if someone has an eating disorder because of their weight? No. So people with eating disorders can be all kinds of weights. Sometimes people lose weight when they have an eating disorder. Sometimes they might gain weight. Sometimes their weight might not change. So that's by itself you can't tell, but there might be some associated change in weight, especially with, for example, anorexia nervosa, where people might lose a lot of weight, and they might be in an underweight range, or they might be underweight for their body. They might have lost a lot of weight compared to the weight they were before. And then we've got eating behaviours around dieting. So typically people with eating disorders have strict rules about their eating. And that means if you have a rule about your eating, you can break that rule, and because you're so concerned about it, you'd often feel you've completely failed. And that could take lots of different forms. People could set themselves a rule of, I must eat 10 grapes, and then if they eat 11 grapes, they've completely failed. So this is very different from, casual terms that we might use around dieting behaviour. People are often very preoccupied with food, and they might engage in other behaviours like making themselves sick, or using laxatives or exercising. And probably the most common feature of a lot of eating disorders is binge eating as well. Often not talked about, but this is where people lose control over their eating. They eat an unusually large amount of food, and they feel incredibly distressed by what's happened. And this is a very common feature across different eating disorders. So, I want to say a little bit about myths about eating disorders. There are a lot of myths, so I can't cover them all. I'm just going to touch on some of these. There is a myth that eating disorders only happen to certain types of people. Young, thin, white, heterosexual, affluent women, for example. But what we know about eating disorders is they can affect anyone of any gender, weight, size, age, race, ethnicity, sexual orientation, socioeconomic status, or culture. Another myth is that people choose to have an eating disorder. In reality, many factors contribute to having this serious psychological condition. Nobody chooses to have an eating disorder, and they're not a phase or a means of getting attention, and in fact many people often try to hide the problem. Another myth is that families cause eating disorders, and in reality people with eating disorders come from all kinds of families, and usually families are not to blame. Sometimes families do develop problems because of having someone that they love and care for who has an eating disorder, and they have ways of trying to cope with that. So families are often a really valuable resource in helping people recover. At the same time, I know for some people out there, they may have had an experience where their family has been unhelpful. So I'm not denying that experience. Families can sometimes be unhelpful, but typically they don't cause all the eating disorders out there. Okay. Another myth is that you can't recover from an eating disorder. So most people who receive one of the recommended evidence-based treatments for an eating disorder get better. Okay. And it doesn't matter how long someone has had an eating disorder for, there is always hope to recover. Okay, so what treatments do we have? Well, there's a specialist body called NICE, the National Institute for Health and Care Excellence, and what they've done is looked at all the different research that there is on different treatments and they've come up with a list of recommended treatments on the basis of this kind of independent evidence review. And NICE have guidelines for all kinds of conditions. And for eating disorders specifically, these are the recommended treatments for adults with eating disorders. As you can see, they are all psychological treatments. And with anorexia nervosa, there are a few different treatments to choose from, including an eating disorder-focused cognitive behavioural therapy. But there are other treatment approaches as well. For bulimia nervosa, there is a suggestion that the first step in care for most people is a form of guided self-help or program-led treatment, where someone follows an evidence-based program with a kind of supporter or guide or coach to encourage them to use the program. And then if they don't respond to that, or if that's not suitable, they can have a therapist-led, a talking therapy focused on cognitions and behaviours. And there's a similar approach for binge eating disorder as well. So, I want to talk to you a little bit about one of these treatments, because I can't talk about all of the treatments in this time. And unsurprisingly, this is the treatment that I specialise in and that our group developed. And this is a cognitive behaviour therapy called Enhanced Cognitive Behaviour Therapy, or CBTE. And you might remember from the NICE guidelines that this is actually a treatment that's recommended for all types of eating disorders. And it's also recommended for people with at different ages, although for adolescents it's recommended you have a family-based treatment as the first line. So, how do we know what this treatment is? I want to just tell you a little bit about it. It takes the form of several sessions, and the number of sessions you have depends on how many things you need to address in treatment. If somebody needs to regain weight as part of getting better, they need a longer treatment to do that, and to also make an informed decision to change if they're ambivalent, which they often are. So treatment might be 20 sessions and 20 weeks, or it might be 40 sessions and 40 weeks. Treatment starts off more intensively. We see people twice a week. And the reason for that is it's quite hard to make changes at the start of therapy. These are difficult changes people are making, and so they often need more support. And then we move to weekly, and then we spread out further towards the end of treatment. And it's a bit like a drug treatment. It's really important to have the full dose and to take the drug or have your sessions regularly. If you just dip in and out, you won't get the same benefit, like if you just took a drug treatment occasionally. So a really important part of treatment is building therapeutic momentum and having consistent sessions. In terms of what we do in CBTE, we always start with drawing a shared diagram with the person we're working with on what's keeping their particular problem going. And we use that as a map of what to work on together. And that includes helping people think about concerns about their body weight. If people are unsure about whether they want to get better, we spend time talking about that, thinking about their worries, thinking about reasons to change, really helping someone to make their own decision. And we help them to have a structure to their eating so that they can eat regularly. And we address whatever particular issues they might have around rules about eating, body image, weight concerns, or people often have difficulties perhaps coping with difficult feelings and emotions, and they might rely on eating or not eating to help to do that, and so we need to give people other ways of being able to do that. And then at the end of treatment, we create a special kind of plan for them so that they can stay well in the future. I wanted to give you a range of resources that you could look at depending on what you're interested in. So there's the Eating Disorder Charity Beat, and they have some really useful information on their website. I recommend the NICE guidelines as well if you want to know more about the different psychological treatments that are recommended and the way in which they should be delivered. We also have a news and information website, cbte.co, which is all about the treatment that our group developed. So we have a lot of resources on there, including all of the research publications that are relevant. And you can also find our research group online, Credo, or follow me on LinkedIn as well. So there's a lot of information for you there. Okay, so just coming towards the end of this talk, and as the psychologist here, I feel it's my responsibility to look after all of your well-being here. So if this talk has triggered some difficult thoughts and feelings, which is very understandable, either because you might be struggling yourself or you might have someone close to you who is, I suggest that you, as Anita described earlier, make sure that you always just give yourself a little moment to readjust. We're going to have a little coffee and tea break soon, and you can feel free to always leave and come back if you need to. So, there we go.
Okay, so this is the moment where you get to ask your questions, and as I told you at the beginning, I'll be taking questions from Hamburg as well. But while Georgina is sorting out the Hamburg side of things, let me begin here. And please wait for that microphone, because then they'll hear you in Hamburg. So I have to do this because the light is in my eyes. Are there any questions? I think something. Oh, there we go. Thank you. And it can be for either of the speakers that have spoken so far.
Yes, my question is for Rebecca. I was wondering how her programme was evaluated, on the success of it.
Yeah, thank you so much. Does this work? Oh, maybe not.
No, it should.
Is it? Is it working?
Yep,
Excellent.
I think it
Good.
is.
Yeah, great question. Because the way in which we evaluate or assess our treatments is really important. So typically, the eating disorder psychological treatments have been evaluated a bit in the way that Sylvane described, which is to look at different outcomes that seem important. So, for example, if somebody has lost a lot of weight because of their eating disorder, then weight restoration might be an important outcome. For other eating disorders, that actually might, weight change might not be relevant. And then there are features of eating disorders, and we have standardized self-report measures where people are asked questions about their eating, and we give those to people before the treatment, and we give them to people after the treatment, and then we give them to people usually, ideally, about 12 months or more later to see if people have sustained changes. So for, say, CBTE, the treatment I spoke about 2/3 of people seem to respond well to the treatment and stay well using those sorts of measures. But having said that, I think the whole area of how do we understand what getting well means is an ongoing process. And that's why I think Anita mentioned earlier about how we want to try and involve people with lived experience, and that's something our group are doing, so that we can perhaps do a better job at co-constructing outcome measures with people with eating disorders, asking them about what's valuable for them, and what do they consider a benefit. Because quite often people might describe more, well, I want to be able to go back to work, or I want to be able to have relationships with people. So there are other areas that I think we should look at too. Does that answer your question? Yeah.
I'm going to take a question from Hamburg because we have a few, and then I'll come back.
Okay, so this person says, I'm particularly intrigued by the link between cerebellar maturation and development of an eating disorder or restrictive eating behaviors, because I research cerebellar contributions to cognition and adaptive behavior. Is there any data on cerebellar changes in recovery from anorexia or bulimia?
I think that's for you.
Yes, thank you. Thank you very much for this question. I'm also very, very excited about cerebellum because it's not a brain area that people typically find associated with anorexia or even include in their analysis. So yes, so we do find cerebellum and cerebellum maturation. We do also find differences in cerebellar activation when we look at functional brain imaging, which I didn't present here. So there is something happening in the cerebellum. So initially, the cerebellum was a brain region that was thought to be important for movement. So when you learn to ride a bicycle, your cerebellum contributes to learning those movements. But now neuroscientists realize that the cerebellum can also have cognitive functions, so involved in cognition and emotion regulation. So this is extremely exciting. What I find exciting in relation to eating disorders is apparently, and this is that has been shown using animal studies, that there is a link between the cerebellum and areas in the subcortex that regulate reward, and that apparently the cerebellum is a brain area that acts as a brake to hunger. It's a way where the cerebellum communicates with another brain area to involve in reward, something that we experience while eating, and say stop. So, and this is this relationship that I find exciting, how the cerebellum, along with other brain areas, can regulate behaviors that are related to reward, anticipation or outcome. So we're going to learn more. We haven't included the cerebellum in our recovery work just for technical reasons, but this is something that we are going to do. Thank you.
Thank you. Very interesting question and answer. I think we have a question down here. Yeah.
Thank you for the talks. This could be a question for either of the speakers or both. I was interested in the correlation with ADHD, and wondered approximately how many cases of eating disorders are associated with ADHD, if that information is available, and if there is a high correlation, does screening for ADHD form part of the assessment for eating disorders?
I can start and then you can finish. So what our data shows differentially, so there is a high correlation between ADHD symptoms and eating disorder symptoms, and especially with ADHD or conduct symptoms with binge eating or purge type behavior, so more the bulimia and that type of eating disorder subtypes. And the correlation, the association is there, and the ADHD symptoms are there before the eating disorder symptoms there, because usually ADHD and conduct disorder appear earlier than eating disorder, earlier in life. So I think that there is a background for emotional and behavioral problems that are shared between ADHD, conduct problem, and eating disorder problems. And I think the underlying mechanism is that disturbed emotional and behavioral regulation. So ADHD shared with binge and purge type eating disorder symptoms, yes. In terms of how many people with anorexia and bulimia and with eating disorders would also have overlapping ADHD symptoms. I'm not a clinician, so I turn to the clinician.
I think it's a good question, and I think in terms of our understanding of neurodivergence generally, so when we're talking about different neurodivergent conditions, ADHD, being autistic, different conditions, we probably are relatively at the start of that sort of journey in terms of understanding the overlap between neurodivergence, ADHD and eating disorders, although exactly as Sylvane said, that the research suggests that people with eating disorders often have higher rates of neurodivergence. So, for example, with binge eating disorder, there's an elevated rates of ADHD in individuals with binge eating disorder. And, for example, for anorexia nervosa, there seems to be elevated number of autistic people experiencing anorexia nervosa as well. And then you asked an interesting question, which is, what's the implication of that for services? What should we be doing? I think one thing that's very tricky for individuals who think that they might have ADHD or they might be an autistic person is that it's very difficult for people to get a diagnosis and to get help with that. But having said that, I think a lot of people might self-identify with particular conditions or ways of experiencing the world, and that can be really useful for them in terms of better understanding themselves and their eating disorder. So the approach that I would sort of recommend, and I think often eating disorder services are doing, is when they're meeting people with eating disorders, kind of listening out for the way that they describe themselves. They might have a diagnosis or they might just describe some characteristics. And in terms of providing information, sharing with people with eating disorders that there are higher rates of neurodivergent conditions, and it might be something that they might want to look into and explore further, because it might really help them to understand what's happening when you're experiencing the sort of interaction or the co-occurring experience as well. Yeah.
Thank you.
Okay, we have a question from Hamburg, Georgina.
Okay, so I believe this is also from the neurophysiology results in the first talk. What were the symptoms that actually increased versus those that were stable in the recovered anorexic groups versus the acute anorexic groups?
$1 million question. This is unpublished results. I would love to tell you what the symptoms that really occur, increase are. I cannot tell you with detail. Of course, I know. But it is something, as I said, that relate to emotional dysregulation. It's the way somebody reacts in a stressful situation and coping, emotional coping. So it's a way that reflects disturbed emotional regulation, and that is very much a reflex, possibly avoiding scenarios or situations that would lead to anxiety. So it's a fear of anxiety, really, that is already there in anorexia nervosa or bulimia nervosa, but both really are compensated during the recovery process.
Do we have another question? Oh, I think we have a few here. Do we have, there's somebody with a cap on over here.
Thank you so much. It's super interesting to hear about it. I was just wondering, because obviously there's been different schools of thought on whether different eating disorders are closer to substance use disorders with problems with reward, or closer to obsessive compulsive disorders, or better thought of as rumination disorders. And the way that you're talking about it, there's it's clearly quite a heterogeneous category. So do you think it's useful that we are grouping them all together and looking at the similarities across eating disorders, or do you think it would be more useful to kind of divide and conquer and recategorize based on mechanism?
Do you want to both say?
Yeah, for either of you.
Go
Yes, absolutely. So I'm looking again at the data and the new direction in science where, trying to remove those diagnostic barriers and look more into symptoms and mechanisms. So that's a message that I wanted to share. We do find share mechanisms and share risks that are common for different eating disorders, but we do also find differences. I didn't go into too many details. For example, we see some personality traits that are more specific or related to binge or purge like behaviors, and others that are more related to restrictive eating. Although I'm thinking, for example, of neuroticism, the tendency to be more emotionally cautious or afraid. So this neuroticism is shared. It's very high in anorexia nervosa, but it's also high in bulimia nervosa, and it is also high in other mental health disorders, in depression. So there is a shared terrain of vulnerability that really can help us to target and prevent early, but also in the development of eating disorder pattern, there are some more specific and unique mechanisms that can be used to target, more personalized approach or subtype specific approach.
Thank you. Yes, at the moment, exactly as you said, there's a particular interest in can we find shared maintaining mechanisms or features which perhaps underlie multiple psychological disorders and make someone vulnerable perhaps to a whole set of characteristics, for example, difficulties with emotional regulation or a tendency to ruminate, or there could be different processes. I suppose what I would sort of add from my perspective is that when I see patients who have not had a psychological treatment for their eating disorder specifically in the past, they've not usually benefited and overcome the eating disorder. Now, I can't tell you that's never happened. I'm sure there are people out there who've had some other more general process-oriented treatment and benefited. But I do think that the evidence suggests that to recover from an eating disorder, you really need an eating disorder-focused specialist psychological treatment from somebody who knows how to deliver that treatment. So I guess that's like a little bit of a argument against the sort of process approach, but it might just be we haven't found the right process approach. And the other thing that's interesting and why we take a transdiagnostic position, and what I mean by that is we're interested in characteristics that people with eating disorders share rather than the differences between anorexia nervosa, bulimia nervosa and binge eating disorder, is that if you follow up people over time, quite often they move around diagnostic categories. And you can imagine if that happened to you, you wouldn't really want to turn up one day for someone to say, oh, well, today you've got anorexia nervosa, this is your treatment, and then you come back the week after, there's a little bit of a weight fluctuation, you're in another category. Oh, we'll give you a completely different approach. And also as clinicians, we need to be equipped to treat a whole range of people. So within eating disorders, I think it's limiting to have a psychological treatment for just one diagnostic category.
Interesting. Okay. Look, I'm going to take one more question from Hamburg, but there are questions, and you'll have plenty of time afterwards. After the third speaker, we'll have another Q&A session. So let's have one more from Hamburg.
Okay. What are some of the unique traits to a relapse prevention plan for eating disorders? Or is it just similar to relapse prevention for addiction and depression? So somewhat similar to the last question.
Is there anything you want to add?
Thank you so much. So exactly as you've said, you're right that relapse prevention plans do share common characteristics. So for example, you might look at things like what are high-risk situations or potential triggers of having a setback. And that's really important if you have depression. or if you have an eating disorder. So you need to know what sort of might, press your buttons or make you more vulnerable to having a setback. But then there are aspects of a relapse prevention plan which would be different from depression and anxiety, because we are targeting different things that are keeping the eating problem going. So, for example, if someone was engaging in strict dieting and they were working really hard to be more flexible with their eating, their plan might include continuing to address some of their rules about their eating. And we talk about what that would involve and so on. So that would be quite different from the sort of plan that you might have in anxiety and depression, but that's because you're working on different areas. Yeah.
Okay, so hold those questions or formulate some questions. Have a cup of tea. Can I urge two things? One is get your tea, because people sort of linger in the queue, and then there's not going to be time, because I'm going to be clapping my hands to get you back in here for 6:30. So go outside, enjoy a cup of tea, and I'll see you back here in about 25 minutes. Thank you. Okay. You've been a great audience, both with your questions and your timing. It's terrific, because now we'll have more time for questions at the end, which I always am pleased about. So, our final speaker this evening is Dr. Katherine Morris. It's our philosopher. Dr. Morris is a fellow in philosophy at Mansfield College here in Oxford. She's written on the work of philosophers such as René Descartes, Ludwig Wittgenstein, Jean-Paul Sartre, Maurice Merleau-Ponty. As well as her doctorate in philosophy, she also holds an MPhil in medical anthropology from Oxford. Her talk this evening, the title is Philosophical Perspectives on Eating Disorders. Katherine, thank you. And there you go.
Okay, can people hear me back there? Yeah, great. I want to emphasize perspectives in the plural. There are multiple philosophical perspectives on eating disorders. It's not really a kind of natural topic that most philosophers would necessarily think about, but I think there are a few strands of philosophy which really do sometimes at least talk about eating disorders. One is feminist philosophy, and that often takes off from the fact that some eating disorders, especially anorexia, are suffered predominantly by women. A second is something called philosophy of psychiatry, which, and philosophers working in that tradition might, on the one hand, try to understand how the minds of those diagnosed with eating disorders actually work, but also, on the other hand, to look critically at practices of diagnosis, classification, and treatment. So that's a second approach. And the third approach, here's a big word, the phenomenologists explore the ways in which those diagnosed with eating disorders experience their own bodies, other people in the world. So I listed 3 articles as possible background reading. I don't imagine that everybody's read those in detail, and they're also, I realize, slightly difficult for some people who haven't got a lot of background. But those 3 articles each take one of those approaches. At the same time, I don't particularly want to suggest that that those approaches aren't combinable. So, for example, the Sylvane article could be called phenomenological philosophy of psychiatry. I'll largely just be commenting a bit on each of these 3 articles and hence each of these approaches. But I want to say right at the beginning that one limitation of all three of them is that they focus almost exclusively on anorexia and not on other eating disorders. Maybe someday some philosophers will branch out. Medical anthropologists have, but not philosophers so far as I know. So just to say a few things about feminist approaches, I'm looking mainly at Susan Bordeaux's classic article. So she begins with a quote from Jules Henry, according to whom psychopathology is the final outcome of all that's wrong with a culture. She notes that psychiatrists and psychologists at least often recognize that anorexia is a multidimensional disorder and that cultural factors are significant in the pathogenesis of eating disorders. But usually these psychiatrists and psychologists, she says, just gesture towards the increasing emphasis that fashion has placed on slenderness, which then gets internalized by some women. So you hear the phrase thin ideal internalization as their explanation of how culture influences all this. She wants to go into a little bit more depth. So she identifies three, what she calls axes of continuity, which converge on anorexia. I should say that these axes have surely got to be relativized at least to, quote, Western culture. That's already way too big a category. But she talks about the dualist axis, the control axis, and the gender power axis, and just to say a tiny bit more about each of them. So dualism is kind of the bifurcation of human beings into the soul and the mind on the one hand and the body on the other, and where the body, there are several things to say about it. One is that it's somehow viewed as alien, the not me, or as a kind of prison, or as the enemy, or as the locus which threatens all our attempts at control. A further thing to note is that very often, according to feminists at least, women are often identified with the body, whereas men are identified with the mind and the will and all those good things. So under that heading, we see quotations like, you know, the drive for absolute purity, hyper-intellectuality, transcendence of the flesh, the idea of being beyond all hunger and desire. Obviously, the term control already gets in there because the body is supposed to be that which threatens our attempt at control. That was her second axis of continuity. And the claim is that people diagnosed with anorexia experience life as well as hunger as being out of control. And this links to a characteristic often seen in anorectic patients of perfectionism. And there's also gender power axis. I mean, clearly enough, she's a feminist. She's going to suggest that, generally speaking, women have less power than men. But she talks in particular about how part of what feeds into some versions of anorexia is a kind of fear and disdain for traditional gender roles, but also fear of the capital F female, which is supposed to be figured as having voracious appetites, both for food and for sex. But I mean, there's a lot more in her analysis, but one thing I think really, there are a number of comments that we might make about this, this analysis, apart from the fact, as I say, that it's quite crude and clearly at best applies to so-called Western culture. One is that it's quite dated. Although it's still viewed as a classic, it was written originally more than 40 years ago. There's a moment in her article where Bordeaux says something like, one of her students, it used to be the case that Marilyn Monroe was viewed as a kind of pure embodiment of beautiful femininity. And one of her students apparently looked at a picture of Marilyn Monroe and described Marilyn as, quote, a cow. So it's very important that fashions for slenderness change, and my students will talk. I should say I teach a course, an option for the Women's Gender and Sexuality Studies master's program here. And it's called Feminist Perspectives on the Body. And one of our topics is eating disorders. And they talk about the Kardashian effect. I mean, that's not slenderness, it's something quite different. It may be equally restrictive, but it's not slenderness. But just to show that fashions do change, that's in the nature of fashions. And so her analysis all seems to presuppose that it's all about slenderness. So there's something a little bit awry there. Apart from that, one of the most astute critics of this general approach is Sue Holmes, she's not a philosopher, which is one reason I didn't put on the suggested reading. She's at UEA, University of East Anglia, in sort of media studies. But she is a feminist academic who herself has experience of anorexia, which is arguably quite important. And she accuses many feminist philosophers like Bordeaux of treating the anorectic as a kind of symbol or a metaphor. She says that these accounts have co-opted anorexic subjectivity as a metaphor for the subordinate position of woman, and also worries that they treat women as kind of cultural dopes. She, as a feminist, feels insulted by explanations of anorexia as an excessive imitation of the slender ideal, which tend to frame anorexics as vulnerable readers of mass media images. And she, as a feminist, is obviously intellectually in a position to realize that, no, that's all rubbish. She has a further dimension when she suggests, still Sue Holmes critiquing Bordeaux and similar approaches, she talks about the political certainty with which anorexia was interpreted and appropriated, in the sense that anorexic or recovered anorexic voices are used by the researcher to interpret the role played by gender. So that's the dimension that they're looking at. Whereas she wants to suggest that, at the very least, not gender per se, but sexuality, she identifies as lesbian, was just as important for the genesis of her anorexia as, and indeed she loves being a woman. She doesn't hate her female body, etc., as she says. Holmes says, I did understand my starving in politicized terms as a product of heteronormative power in society, not just patriarchal. And one of my students on that course just adds a further dimension, because she saw it as all about starting out trying to be healthy. So kind of then starting to merge with something that's popularly known as orthorexia. Anyway, so much for feminist approaches. I want to say a tiny bit about Jennifer Radden's article. Her basic argument is that it's unclear whether anorexia ought to be pathologized. After all, behaviorally, she argues that an anorectic patient is much like a hunger striker, whom we don't pathologize. And the reason we don't pathologize the hunger striker is because we see hunger strikers as having clear, comprehensible motive for their behavior. And one of the things that Radden wants to claim is that the motives as expressed for their anorexia, as expressed by anorectic patients, are often hugely ambiguous and hard to interpret. She looks at a whole collection of quotations from various sources. A lot of them have to do with their own sense of identity. So, for example, it's almost like having two bits of you that are you all the time. The bit of you that's really scared of food, and the rest of you that just wants to be able to get on with things. And I was struck, Rebecca mentioned that anorectics, well, I don't know if it was anorectics in particular, are often ambivalent about getting better. And arguably that's got something to do with the ways in which that anorectic self has become part of the person's self. So some interesting reflections there. There's a lot more in there, but I just wanted to bring out that much. The approach with which I'm most familiar and feel most comfortable in is phenomenology. And I'll have to say a couple of words about phenomenology. It's a big word and it's a hard word. I've asked you to, or the article on that short reading list is by Sylvane. But phenomenology as a philosophical enterprise, very basically, first of all, is to describe lived experience, not necessarily understood as culturally unmediated. I think that's important. But then to relate that lived experience to various fundamental structures of human reality. The most fundamental of all, for many phenomenologists, being what they call the lived body. They contrast the lived body with the body thing, which is studied by physiologists and anatomists and so on. This is the body as it's lived in lived experience and in the life world. And Sylvane picks up on some well-known contributions to the phenomenology of the lived body in his analysis of anorexia. Interesting, just to, as a footnote, there's a tendency to think of eating disorders as, quote, mental. But of course, if you reject dualism, as phenomenologists do, it might not seem so strange that what we've got is certain disorders of the lived body. So one of the philosophers he picks up on is Sartre, who talks about the lived body for others, where the idea is that if I'm aware of being looked at by others, I almost instantly feel shame, according to Sartre. And that notion of shame is often viewed as quite central to a number of eating disorders. There's a more sociological concept of stigma, which is also related. According to Sylvane, who's read a lot of these narratives, most narratives of anorexia seem to start with a scenario in which a young girl suddenly understands, by way of comments on behaviors or behaviors of others, that she's, quote, too fat. That gaze that sort of thinks paralyzes us with shame sort of gets internalized and becomes a self-objectifying gaze. And one of his central concept throughout the whole of the article is the notion of being alien or being uncanny. I'll say more about the uncanny in a moment. But according to him, one's own body, when it's suddenly revealed by others to be, quote, too fat, becomes sort of alien to oneself. He also comments that the anorectic body itself becomes something alien to others when it starts exhibiting this kind of skeletal look. And if you ask, which he doesn't, but I want to, why doesn't that look of horror on the part of others make the anorectic feel shame? And part of the answer, I'm guessing, is going to be because she's increasingly feeling disembodied and distant from her body. So another aspect of all this, so we've got girls becoming alienated from their own bodies because others are judging them as fat. We've got others finding the anorectic body rather alien. He also talks about Richard Zahner's notion of the body uncanny. The alien nature of embodiment, which makes itself known when the body displays needs that I do not control. And as Zahner puts it, if there's a sense in which my own body is intimately mine, there's a further and equally decisive sense in which I belong to it. It forces me to turn away from what I may want to do and attend to my own body. And as Phineas notes, to experience the bodily changes of puberty can be an uncanny experience when the body kind of takes on a strange life of its own. He doesn't actually talk much about hunger, strangely. That's one of Zahner's paradigms of the ways in which the body kind of makes you pay attention to it. Bordeaux does. She describes hunger as a kind of alien invader. But just to say a couple of more things. The final mode of alienation is that this routine of surveying and controlling eating soon develops into a pathology with a life of its own that the person is no longer able to control. And this may lead some anorexia sufferers to view the illness itself as something alien. And you even hear talk about a kind of demon inhabiting the body, not taken quite literally, but it's often experienced a bit like that. He concludes that a feminist reading is a little too one-eyed, as he puts it. No one would deny that cultural norms have a lot to do with the onset of anorexia, but it's a non-political reality that illness, when it has established itself, takes on a kind of life of its own as an uncanny pattern of experiences and, quote, musts that are not easily dealt with and changed, no matter how politically informed the anorexic girls, her parents, or caretakers become. So those are just a few perspectives from philosophers on, well, anorexia in particular. I'll stop there.
So another, as it were, dimension, really the cultural dimension being brought in there. So I think there were some questions here that we didn't get to answer before, but now we can bring in questions for all three speakers. And I'll start here, and then I'll ask in Hamburg. So do we have, yeah, there's a question over right in the middle by the wall, please. Make sure the microphone's on, yeah?
Hello. I've got a question about cross-cultural and ethnic perspectives. I'm just thinking about the first speaker, and one of the issues you talked about was BMI. With regard to BMI, at least on the upper levels, people from ethnic minorities, we have a lower cutoff for measuring overweight, very overweight, and severely obese. Is there any food for thought in terms of the science community looking at a different cutoff for anorexia? Because obviously we don't diagnose anorexia purely on BMI, and it's part of a kind of a whole cluster of symptoms. But certainly, as a clinician, I see lots of young women with very low BMIs, but they don't have any issue with body shape, image, dietary restriction.
So you meant the first speaker, me. So we do undeniably see that BMI is a risk factor for eating disorders. So far, scientists use the clinical definitions of BMI, and usually it's a cutoff of this number. And I haven't seen, and correct me if this is different, different BMI threshold being used for different populations, although it is obvious that different ethnic groups have different BMI. Right? So yes, I do think that this should be something that should be taken into consideration in clinical practice. What I do think also is that we're trying to develop predictors so that we can ditch BMI from diagnosis of eating disorders, and if we can try to have some markers, early markers that could, predict or stratify different groups of people with eating disorders, that could work without a mention of weight categories, that would be something good. But in clinical practice, I don't know whether different BMI thresholds are currently being used.
Yes, so body mass index is becoming, I think, increasingly considered limited because it was only ever designed as a measure of population health. It wasn't actually ever designed for you to take a single individual and draw conclusions about their health. So it's problematic, and I think, as you said, it's certainly problematic used on its own. So if somebody's not having any problems with their eating, they wouldn't have an eating disorder just, on the basis of BMI alone. And as you say, with certain minoritized ethnic groups, they've got different BMIs that you need to be considerate of. So the way we tend to approach it in CBTE is we're thinking more, is this individual's weight range that they're at now contributing to keeping their eating disorder going or not? So with that, you would take into account personalization as well. I think a lot of the BMIs are looking at the World Health Organization data, which is sort of generalized across different populations, but certainly biased towards white population. So it is problematic to use with different individuals. And also you've got the complexity of many people having dual or multiple heritage as well. So yeah, that's a good question.
Right, I think I'll take a question from Hamburg.
So this one's quite quick. Are there established animal models for eating disorders? Because there even seems to be one for borderline personality disorder, which you maybe imagine would not be possible.
Can you repeat the end of the question? So animal models for eating disorders?
Yes, so this person says, are there established animal models for eating disorders? They're curious because they've heard that there is even one for borderline personality disorder, which you maybe imagine wouldn't be possible.
So using animal models for mental health issues or human, so they do not model one-to-one the human condition, but they are very, very helpful. In terms of eating disorders, there are animal models that try to model behaviors, for example, uncontrolled eating or restrictive eating. So these are used and can be very, very informative. And that's where I looked at the effect of the cerebellum that was already found in animal models and action and impact on eating frequency and eating in animal models. With that said, there are limitations with animal model, and I'm not sure how we can really model all complex factors that are involved in the development of eating disorders, or you can model social factors. We haven't talked very much about which social inter-individual interactions, stress factors can be modeled in animal models or trauma. So not everything can be modeled so far in animal models, but there are some animal models for eating disorders that have been very useful in identifying some basic eating behaviors.
Okay, I think, do we have a question? Okay, can we have the woman with a red band on her wrist? Thank you.
Thank you for all the great talks. My question is for Rebecca. I'm wondering about your experiences and views on family and care involvement in treatment of adults in services.
Yes, thank you. With the main model that I'm familiar with and that we tend to use in adult services, which is a form of cognitive behaviour therapy, the family and significant others in people's lives are an important part of treatment often. So we work with the individual who's bringing about change themselves, but we want them to be in the optimum environment for change. So families can be really useful in terms of helping to create the best environment for people to be able to make changes. So the way we would tend to do that is work with the individual and think about what would be more supportive for you in your environment, what would it be helpful for your family to do, what might not be helpful that they might inadvertently be doing, and then sort of get the family in and talk about changes that they could make to help the individual to be able to try and do the things that you agree in therapy. So that's the sort of approach that we tend to take. Does that answer your question? Yeah.
Okay, do we have another one from Hamburg?
Yeah. So this is for Dr. Morris. How do those affected and those treating them deal with the fact that socially idealized body images, such as very slim aesthetics, potentially conflict with the goals of recovery for people with anorexia? And is there any evidence that such ideals influence the motivation to recover?
Sorry, I think I missed the first. Could you just read that question again? Sorry.
Yeah, no worries. How do those affected and those treating them deal with the fact that socially idealized body images, such as very slim aesthetics, potentially conflict with the goals of recovery for people with anorexia? And is there any evidence that such ideals influence the motivation to recover?
I have to say, I think that's more a question for the others, because you're asking about evidence. The fact, it does seem to me that social media, in principle, today, is having an enormous effect on the ways in which, I mean, for all kinds of reasons, but partly simply because you're always being looked at, you're always on display, you're always in a position to be comparing yourself to other people. Quite apart from that, there are websites, so-called pro-ED or pro-ANA websites, which can provide a lot of help and support for people with anorexia, but at the same time, sometimes at least, they're doing something that sounds a little bit more sinister, like telling people how to hide what they're eating, or hide their body shape, or pretend that they've eaten when they haven't, and so on and so on and so on. So it seems to me that the whole social media environment is potentially pretty bad for anorexics, but as far as evidence that it's making things worse, that's evidence is all in the hands of psychologists and neurophysiologists, not philosophers. Yeah.
Just on that, I certainly see in my clinical experience that the influence of diet culture and the thin ideal, it can be very unhelpful for people trying to recover from an eating disorder, living in a society which values dieting and values thinness, to be able to make changes. And I recently went and did some training in the United Arab Emirates, and people there were talking about how difficult it was that they were dealing with both the sort of traditionally Western thin ideal that people were trying to aspire to, often women, but other people, other genders as well, trying to aspire to a thin ideal, whilst also culturally in the UAE and other cultures, a different type of more curvaceous aesthetic was also seen as desirable. So it was particularly challenging for people who were sort of internalizing two different versions of what it means to be, you know, an ideal woman or an ideal person. So I think also if you look at, for example, the rates of bulimia nervosa, quite often you have higher rates in more sort of traditionally westernized cultures, and if you look at cultures as they change over time, the more they adopt Western ways of thinking about things, the more you have an increase, for example, in bulimia nervosa. So I certainly think that this idea, this sort of whatever the ideal is of the time, will have a powerful influence on the development of eating disorders.
Actually, it made me, can I quickly ask, do we have any evidence about different cultures and the predominance of these disorders in those cultures? Are there some cultures that have more? I mean, you seem to indicate there that ours is one of those cultures.
The research is complicated, just to say that. And one of the reasons it's complicated is because quite often the measures of eating disorders are developed by, for example, Western cultures, and then it's problematic to use them in non-Western cultures because they have a different meaning. So it is quite complex, but just sort of crudely speaking, it does look as if, for example, anorexia nervosa is relatively stable across time and across cultures, but the form in which it takes will be different, perhaps depending on the internalization of whatever it is that culture values. So for some cultures it might be about the thin ideal, for some it could be more kind of purification and other reasons. But bulimia nervosa, for example, I think it certainly looks as if culture plays a big role, and in terms of influencing the tendency that people have to engage in strict dieting. And so I would say there is kind of evidence that culture plays a role, but it is complicated by methodological challenges. I don't know if you knew any more, Sylvane, from your...
No, no. Just to add that actually, too little research using participants from non-white, background is being done. Most participants, and even in our own studies, people answering our ads are female, white, Caucasian. We try to encourage more, diverse participants to be part of our study. That has worked a little better with our covered participants, but more should be done. We should study different groups, cultural groups, and how eating disorders develop and are affected by those cultural differences or not. Yeah, so absolutely, we need to know more about differences or not.
Thank you.
In this context, actually, I was...
into the microphone, please.
Sorry. I was wondering that the assumption of a lot of people working in the area is that anorexia and similar disorders are the province of females almost exclusively, but I know there is some evidence that while females are a majority among those with eating disorders, that some boys and men also have eating disorders, and I was wondering to what extent these males with eating disorders differ from females with eating disorders, or if it's very much the same sort of characteristics.
I will just say very shortly. It is extremely difficult for us to engage male participants in our studies. With new studies, with collaborators that we all know, we try to really reach out to male or more participants so that we can answer those important questions. So far, we do not have male data. I would assume that there would be some different triggers, between males and females, and it will be important to identify those. But in the clinic, you can have maybe a different picture.
Yes, so I think you're right that sadly as well, a lot of our research studies are with individuals who are female. Having said that, for example, the work we're doing at the moment with our digital program addressing binge eating, we do have quite a few men actually taking part in receiving this sort of form of treatment. And I've spoken to them and I've asked them about their experience of the program and whether they feel that it's kind of speaking more to women or whether they can relate to the advice and description of eating disorders. And as you might imagine, there's sort of a range of views. I think quite often there are aspects for many men that are similar across genders. And at the same time, there are also differences. So, for example, if we're talking about culture, for women, they might internalize the thin ideal. For not all men, but for some men, they might internalize a sort of muscular image. So they might have different pressures in terms of what they consider to be an ideal aesthetic. That may mean that they do engage in unhelpful ways of eating, but it might be a little bit different from the unhelpful ways that people might engage in if they are sort of aiming for a more emaciated state versus trying to kind of build up muscles. So I think there's some similarities, some differences, and we certainly want to involve more men and people of all genders as well going forward in our work.
Thank you.
I think, did you have a question? Can we have the microphone over here? We're going to have to try and keep it a little brief. I'll get a couple more questions in.
Thank you. I just have a question about age, because we've talked a lot about puberty and development through teenage years. I guess it's a question for everyone from your different kind of fields. How do you make sense of eating disorders that develop later? I know there's a spike sometimes when people go to university, sometimes even later in life after big life events or stressors. Just wondering how that's different, if at all, if the evidence looks different, for instance, from a neuroscience perspective.
Okay. So thank you for taking this developmental approach to eating disorders. So I do think that age matters. First of all, early adolescence, because there is this puberty, and possibly due to several factors, hormonal changes, in addition to other changes, peers, interaction. So there is a lot going on at this early adolescence period. But also other changes later in life occur. For example, you mentioned going to university or transitioning from living at home and then getting to your independent life. So I think developmentally there are transition periods that are very important. Starting, for example, with puberty, with early adulthood, that is usually now during between ages 18 and 25, where young people try to stand up for themselves and have some ground in society. So transition periods that are very associated with stress and how every individual reacts to this or cope with those external factors that may involve stress, trauma, or just changes in life. So developing coping mechanisms at different important transitioning periods in life. So we focus on adolescence and through early adulthood because this is where things start to develop, but that doesn't mean that later on in life, some stressful, anecdotal for me, but stressful life events that occur later in life could also lead to manifestation in eating disorders.
I'm actually not, because you were nodding, I thought, it sounds like you're all in agreement on that. Is there one more question? Okay? Yeah, and we'll try and keep it brief because we're actually out of time, but I'm going to just let that happen.
I was really interested in some of the philosophical perspectives on eating disorders and how our understanding from that perspective might inform clinical practice. So, for example, thinking about the uncanny and the unfamiliar and an illness taking on a life of its own and therefore feeling quite uncontrollable, how in clinical treatment psychologically can we make accommodations for this, thinking about uncontrollability and perhaps about kind of externalization of an illness, but it would seem quite difficult to treat that psychologically if that is the case.
In a way, sorry, but I kind of think that's more a question for Rebecca, in one sense, because it does seem to me that the way you were talking about the cognitive behavioral therapy made it sound as though what you're trying to do is give them ways of dealing with feelings of things being out of control, life in general, or whatever, or eating, or whatever it might be. So, but that, it sounds like that's kind of exactly the kind of thing that, go ahead.
So I think it is interesting. It's interesting to look at the ways in which philosophy conceptualizes eating disorders and then think, how does this apply? Absolutely, as you said, because some of the theories you were describing use an externalizing type of approach, which is where they talk about maybe the eating disorder having a life of its own and being separate from oneself. And different psychological treatments actually take different positions on this issue of externalization. So, for example, there's a treatment for anorexia nervosa where it's helping people to externalize as a way of understanding the eating disorder voice, and that's a therapeutic tool to help people to perhaps kind of have some distance from that, but also to sort of understand it better, and potentially even kind of fight together with the family against this sort of externalized force. And for example, in CBTE, we actually don't, so our model, we don't externalize, we think of it more as you could think of an eating disorder mindset, but it's more of a particular way of thinking and understanding things. But at the same time, someone might also have a healthier mindset, and it would be more about helping people to put a healthier mindset in place and eject the eating disorder mindset, rather than of sort of externalizing it as a kind of separate force. So yeah, I think it's interesting to think about those different approaches.
Okay, on that note, which kind of brought the different speakers together, thank you very much. Let's thank our speakers. And I do look forward to seeing some of you in Trinity term or in the spring term, where we'll be doing movement sport in the brain. And I do think that's going to be quite interesting. So hope to see some of you again.